Welcome everyone to today's webinar. I am Mackenzie Bean with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. John D. Halamka, MD, MS, is Chief Information Officer of the Beth Israel Deaconess Medical Center, Chief Information Officer and Dean for Technology at Harvard Medical School, Chairman of the New England Health Electronic Data Interchange Network, CEO of MA Share, the Regional Health Information Organization, Chair of the U.S. Healthcare Information Technology Standards Panel, and a practicing emergency physician. As CIO of Beth Israel Deaconess, he is responsible for all clinical, financial, administrative, and academic information technology, serving 3,000 doctors, 12,000 employees, and 1 million patients. As CIO and Dean for Technology at Harvard Medical School, he oversees all educational research and administrative computing for 18,000 faculty and 3,000 students. He also runs a blog at geekdoctor.blogspot.com. Alexi Normand leads B2B activities at Nokia Digital Health, having started the healthcare department of Withings before its acquisition by Nokia. A graduate of HEC Sciences Po and La Sorbonne in philosophy, he has a background in public policy, healthcare reform, and industry. A digital health evangelist, Alexi is active within a French think tank, La Fondation Concorde, and has published a book, The Revolution of eHealth. Dr. Halamka, I will now turn the floor over to you.
Well, great, and very happy to present to this audience because all of us, not only in the United States, but throughout the world, are wrestling with how do we incorporate patient-generated healthcare data into our daily workflows. Because we know that the electronic health record over the course of the meaningful use in high-tech era has imposed burdens on clinicians, asking them to now review patient-generated healthcare data if we give them simply raw data feeds could be increasingly problematic. So why don't you go ahead and give me that next slide. So what are the problems that we need to solve? I was in Scotland over the weekend. I was in New Zealand last weekend. I'll be in Africa next weekend. Every one of these societies is facing the same challenge. Healthcare costs are increasing as society ages, and there are fewer people paying in to support that ever-increasing healthcare cost. We know that one way to alleviate some of these costs is to provide care navigation, decision support, engage patients and families so they make better choices. But yet, across all societies, including the United States with our Meaningful Use program, we've really given very poor tools to our patients and families. So for all of you who are listening, I'm sure you have a portal. In fact, you probably have 5 portals, one for your PCP and one for your specialist, one for urgent care, one for inpatient, one for post-acute care. And trying to figure out what data is relevant and what steps you should take to stay healthy is increasingly challenging. You could probably go find out that your serum sodium was 139 last week. Woohoo! Doesn't help you at all with navigating wellness and achieving good outcomes. As I mentioned, 50% of doctors in the United States want to quit because the electronic health record is overwhelming. I wrote a piece in the New England Journal a couple of weeks ago reflecting on the era where we implemented high-tech and ICD-10, the HIPAA Omnibus Rule, and the Affordable Care Act all at the same time, so that clinicians had to enter 40 structured data elements, protect their data, encourage their patients to use portals and secure email, and be empathetic and never commit malpractice. It is impossible. We have, in the United States, improved our capacity to exchange data provider to provider and provider to patient, but still, we lack important enabling infrastructure. So imagine your name is John Halamka. Well, that turns out to be relatively easy to deal with because there are only 13 Halamkas in the United States, although my name is misspelled in every single healthcare registration system. But imagine your name is Maureen Kelly, and you're an Irish American living in a neighborhood like South Boston, which is filled with Irish Americans. Being able to match your records across EHRs is impossible if you use name, gender, date of birth, or other demographics. So how can we expect that we are going to provide clinicians a lifetime medical record view of patients' inpatient, outpatient, and home experience if we can't even figure out who the patients are? Or what if we want to send data from doctor to doctor, but yet we don't have the electronic addresses? There's no directory of where the doctors can be reached. Very challenging. Or hey, how about you live in Massachusetts, where I am standing currently, and want to send data to New Hampshire, just across the border a few feet? Wouldn't it be lovely if the policies for privacy and consent were actually the same across the state border? Well, it turns out, and just to give you a real example, in Massachusetts, we believe that it's a public good to collect immunization records. We believe it's a public good to look at syndromic surveillance and outbreaks, Ebola. We think it's really important to manage laboratories like HIV, TB, and make sure that if there is a community risk to the population, that is addressed proactively. And in New Hampshire, everything I've just said is illegal. No doctor may send data to a state public health entity because that's too much government in your face. So try managing this across 50 states and 6 territories. It becomes impossible. And in the United States, we spend more per capita than any other country in the world, yet we don't have the outcomes, the lower morbidity, the longer life, the decreased infant mortality, the things you would expect if we had a high-quality, high-performing healthcare system. So you may get great care or not, because every doctor is trained as an apprentice, and there's significant variations in healthcare quality. So I don't mean to depress you, but these are the nature of the problems that we are really trying to solve in society today, in a system that is still fee-for-service, driven by insurance companies, and highly fractured. Next slide. So what about the journey so far? Or what can we say? Well, we spent $31 billion on healthcare IT through the high-tech era. And we do have to acknowledge, because see, this is not pessimism here, that we moved the bar from 10% adoption in hospitals and doctors' offices to 90% adoption. And I can tell you, no other industry has moved so far, so fast as healthcare in the high-tech era. So let's pat ourselves on the back. But as I said already, we did move a little faster than culture would allow. We moved a little faster than probably not only our doctors, but our nurses and social workers and all caregivers could accept and could adapt in their daily workflows. Although patient portals and patient-facing software, B2C, has been offered in many contexts, it's not widely adopted. It's not widely used. And let me give you a quick case example there. A friend of mine, Adam Bosworth, who originally ran Google Health's products. And Google Health, by the way, was a little ahead of its time, nicely engineered, but no one was quite sure of the value proposition, so it ultimately shut down. Adam was telling me when he founded a company that he had a great idea, that what he would do is he would provide laboratory data interpretation. And wouldn't patients find that valuable? So what happened? He spent millions of dollars. He built a website. Patients went one time and said, oh, my cholesterol 200 is bad. Okay, done. And never went back. It was not engaging. There was no call to action. There was no mechanism for looking at your data versus others' data and figuring out what lifestyle changes you should make. So then Adam said, I know what we need. Care plans that your diseases, diabetes or others, will have an expert reviewing them. And then once you get a care plan, you can act upon it. It'll be great. Patients came, they got a care plan, and they saw, oh, diabetes, get an eye exam, get a foot exam, don't eat so many concentrated sweets and exercise. And they never came back. So finally what he said is, let's create a highly interactive social network that's updated with daily observations from patients like you, and we will all get healthy together. And you know, that stuck. So I just mentioned that example because there's this need for creating a new generation of patient-family engagement that's highly interactive and highly actionable and gives patients some true value. Now let's keep in mind that while we're creating this data sharing, provider to provider, provider to patient, cloud and mobile, we're also being faced with increasing security challenges. All you need to do is open up the New York Times this morning and see, oh, Equifax underestimated by just a few million people the number of folks breached. In fact, it's safe to say that every adult in the United States was breached in the Equifax security issue. So how do we build confidence among our patients and providers if we say we must share more data from more devices for more purposes and yet keep it secure? It's an interesting challenge. And finally, I think it's safe to say that over the last several years, we have seen the pace of innovation slow as many of our major vendors, and I mean Cerner and Epic and Meditech and eClinicalWorks and Athena, have had to pay attention to regulatory demands. Over 10,000 pages of new healthcare IT-related regulations have been passed in the last several years, and hence the kinds of usability or value-enhancing innovations we would want have been co-opted by federal government regulations. So there's a lot of dissatisfaction among all stakeholders. So that's our experience. Some good, but some not so good, and still a gap in where we want to be. So next slide. And so where is it we want to go? So I believe that if you look at the next couple of years, we are going to see innovation from third parties that add modules, that add hardware, that add unique functionality that layers on top of our existing electronic health records. And we're seeing some good evidence of that already. Epic and their Orchard, Athena and More Disruption Please, Meditech, others, they're opening up their EHRs to third-party developers to get and put data that is going to be more value added. And maybe some decision support, some analytics, some things that are going to provide doctors and patients with action. And sure, I mean, Cerner, Epic, Meditech, Athena, ECW, they're all great companies, but they're still going to be dealing with a variety of transactional systems necessary for regulatory compliance and getting the bills out correctly and dealing with whatever happens over the course of the Affordable Care Act revisions and the move to the Quality Payment Program, value-based purchasing, and patient perspective payment system, and those other things. So we're going to see modules and apps and functionality that is going to come out of other third parties that is going to be the real centerpiece of innovation. What I hope over the next couple of years, and I spent a lot of time talking to our national coordinator, Don Rucker, that we as a country accelerate enabling infrastructure through the use of fast healthcare interoperability resources, FHIR, APIs, through the use of not a national patient identifier, but a nationwide patient matching strategy that is well understood by everyone. Could be biometric, could be a card, a bit like your TSA pre-check or global entry. It's voluntary. It's not some given at birth national healthcare identifier. Some rationalization of policies through at least some common guidelines and frameworks, and some data governance, that we all understand how you can use data and for what purposes patients will allow. I think we're also going to see an incredible increase in the number of connected devices And I'll tell you in a moment a couple of stories how I personally have used connected devices in my home and with my family to improve care. We all know that we spend 17% of our gross domestic product on healthcare, and that is not sustainable. So when I was in New Zealand and Scotland, I asked the same question, how much do you spend? And they each said, oh, about 5 or 6%. China, 6%. We're spending 3 times what every other country is spending. We have to move away from fee-for-service to pay for outcomes, pay for quality, keep people healthy in their homes. Don't have them visit hospitals and doctors' offices unnecessarily. I think what we could also say is over the next several years, just sort of the nature of the current administration is we are not going to see a vast amount of new regulations. That means that the private sector is going to drive innovation. It won't be a lot of top-down government mandates. So next slide. So where is all this leading? So let me give you a sense of how I think we can do better. And by the way, for those who are listening, don't worry. My wife and I and my daughter and my father and my father-in-law have all signed consents in the compliance office of Beth Israel Deaconess, allowing me to share every intimate detail of their medical history. No HIPAA issues here. So it was about 6 months ago, and my wife said, I have had my heart rate elevated for about the last month. This was not an acute issue. This was not a heart attack or a pulmonary embolus or something that had just started. It was a chronic elevation of heart rate, because our usual heart rate's around 60 or 70, to 110 every day, 24 hours a day. Oh, and I'm walking less and feeling a little fatigued. And my hair is really brittle. Oh, and I've lost weight. I step on the scale every morning and it seems like my weight is going down, and I didn't anticipate that. What I've just described to you are the symptoms of an overactive thyroid gland. In effect, it's like your body being on speed 24 hours a day. So what did my wife do? Did she drive 2 hours down the Massachusetts Pike to park in a $40 a day Boston parking garage to see a Harvard specialist after waiting for several hours? No. She picked up her mobile phone. And because Beth Israel Deaconess has secure doctor-patient texting, she said to her clinician, I have measured my weight, I have measured my blood pressure and my pulse, I have certain subjective observations about my hair and my fatigue and my energy, and it appears that I may have a thyroid problem. Now, I recognize not every patient or family is going to be able to do something like that, but in this case, the clinician responded via secure text. Could be, don't know, but it is a reasonable next step to measure some laboratories. I will order a TSH, a T3, a T4 to be done at a lab right near your home. It's not going to be downtown. It's not going to be expensive. It's going to be a suburban location with free parking. And by the way, they send the lab results to your mobile device a few minutes after they're completed. My wife drives down, gets the labs done. An hour later, we see her T3 and T4 are 5 times normal, and her TSH is 0. So she has an extraordinarily overactive thyroid gland. She has hyperthyroidism. She picks up her mobile device. She securely texts her doctor and says, Doc, probably I need a specialist. What do you think? And the doctor says, yep, we probably need to get an endocrinologist to see you. And it just so happens there is an appointment available tomorrow at an endocrinologist's office near your home, free parking. She goes to see the endocrinologist, gets one more lab test, thyroid stimulating immunoglobulin. And the endocrinologist says, you have Graves' disease. It's an autoimmune condition. It's treated either with surgery, radioactive iodine ablation of your thyroid, or a pill. Well, what do you prefer? And my wife says, oh, let's try the pill. And so the endocrinologist writes for 10 milligrams of methimazole. He prescribes it to the pharmacy that is 25 feet from our house. My wife walks over, gets the methimazole, takes it, and 2 weeks later, all the symptoms are gone. So think about what I've just said. It's the interaction of devices in the home, of mobile technologies, of pharmacies and labs, PCPs and specialists, all knit together at almost no cost. And in a global capitated risk environment or value-based purchasing environment, remember, you're paid for not ordering more tests or doing more work. You're paid for high-quality outcomes. So in this case, her doctor did the right thing. My wife was thrilled, and the doctor ends up getting paid more. Well, here's my own personal experience. I'm a vegan, body mass index of 21, run a farm, couldn't be healthier. I eat nothing but rocks and sticks, walk 15 miles a day. Imagine my shock when I use a blood pressure cuff and find that my blood pressure is 170 over 100. I think, oh my, I must have just, put the cuff on wrong. Tried it on the other arm, did it again, 170 over 100. I text my primary care physician and say, new onset hypertension. And my physician says, well, let's do the medical workup. Let's look at your kidneys, creatinine, let's do an EKG, make sure that it isn't the bad stuff. But then, if it isn't the bad stuff, let's make sure it's not lifestyle. Maybe you're just over anxious driving the Massachusetts Turnpike. Traffic's horrible. Maybe you're drinking too much tea and the theobromine is tipping you over the edge. Maybe your work environment's stressful and your boss is difficult. So could you use a mobile device to measure your blood pressure before and after commuting, before and after your tea, and before and after meetings with your boss, and send that to your phone and share that data with the electronic health record so that I can take a look at lifestyle correlation to symptoms? So we do all that. My creatinine's 0.4. My EKG is totally normal, heart rate of 45, and no issues with driving, drinking tea, or meeting with my boss. So my physician concludes, this is a genetically inherited primary hypertension because, in fact, my father had hypertension, my mother has hypertension, their parents had hypertension. It just took 54 years for it to show up in me. And this entire diagnosis was done with Bluetooth devices in my home, going to my phone as middleware on the way to my doctor's office and the EHR. So my doctor said, we better write you for some meds. ACE inhibitors, beta blockers, calcium channel blockers. What should we choose? Well, it turns out I have another medical issue. 2 or 3 times a year, my heart rate goes from 45 to 170. And in 15 years, no clinician has ever been able to capture it on a Holter monitor or stress test. Why? Because a Holter monitor is on your body for 24 hours and gone. If it happens 2 or 3 times a year, you'll never catch it. So what do? Well, I buy a device that's Bluetooth enabled and enables me to capture an EKG while I have my phone on my body. So I may have a Holter monitor 1 day a year, but I have a phone 20 hours a day, 365 days a year. The arrhythmia happens, I grab my phone, I measure, and what do you know? I have an atrial tachycardia, and I'm able to send a rhythm strip to my cardiologist in real time, and then my cardiologist says, aha, new primary hypertension, atrial tachycardia, metoprolol XL 25 milligrams, and you will be cured. I don't know if any of you listening have ever taken a beta blocker, but a beta blocker is like reverse coffee. Imagine if not only you didn't get your morning coffee, you got reverse morning coffee. That's a beta blocker. So I securely interact with my clinician saying, took the beta blocker. Blood pressure is 110/50, heart rate's perfect, no arrhythmia, but I feel like crud. I can hardly get my work done every day. So we interactively, through a mobile application, titre the medication from 25 to 12.5. I cut it in half every day. And I'm cured. My symptoms are gone. I have normal energy. And all of this was done, again, with mobile devices in the home, interactively with my clinician in a matter of days at near zero cost. And finally, one of the things you hope, as we gather all this data about patients and families and symptoms and response, that we have the opportunity to use the patients of the past to decide on care plans for patients in the future. And so imagine that, in my case, we have a patient with breast cancer. My wife was diagnosed with stage 3A breast cancer in December of 2011. She's a Korean female, age 50. And wouldn't you want to know, for Asian females age 50 with this kind of cancer that has a certain kind of genome, what other patients experienced? Did they get chemotherapy, radiation surgery? What were the impacts? What were their side effects? So we were able to mine a variety of data systems at Harvard and actually figure out that for my wife, we should divide her Taxol dose in half if we want to avoid very significant side effects like a neuropathy that reduces a patient's ability to feel their hands and feet. So say you have objective data that shows everybody who gets Taxol can't feel their hands and feet and can no longer go for long walks or accomplish their activities of daily living. Shouldn't that inform patients in the future? In the case of my wife, since we reduced her dose in half, at the end of her treatment, she had total cure with no side effects, and to this day is in remission and completely fine. So this data we're gathering isn't just for single patient care coordination. It's for population health and care management. Next slide. So I want to actually show you some examples of the kinds of things we've done at Beth Israel Deaconess. We believe that the patients, the doctors, the nurses, they don't want laptops or desktops. Everything is about mobility. In fact, I can tell you today, 80% of all of the accesses of software at Beth Israel Deaconess, patient or provider, are done via mobile devices. Whether that's an iPad, an iPad mini, an iPhone, an Android device, we don't care. We try to do everything in a device-neutral fashion that enables patients, providers, and all caregivers, including families, to gather the information they need on their mobile device. Our electronic health record runs just fine on iPads and iPhones. Nurses tend to carry smaller devices, doctors a little larger devices. And that's often because the clinicians are entering orders, need a little bit bigger device. Patients access all of their data, and as I'll show you in a moment, all of the patient-family engagement applications via the phones. Images are exchanged via phones. And kind of an interesting new app we've created for patients and families, an ICU application that enables them to watch the progress of their loved one in the ICU, including their numeric values, their care plans, and activities of the day, all via mobile devices. Next slide. So I've been talking about the need for better patient-family engagement. It's not just showing your serum sodium. It's not just sending the patient some static data. And so let's look at how you might improve the care of a patient with congestive heart failure. So imagine in the EHR, and Beth Israel Deaconess is the last hospital in the United States to self-build an electronic health record, but Epic and Cerner, Meditech, Athena, eClinicalWorks, they're all doing similar type stuff. And imagine the patient picks up their mobile device, sees their care plan for the day. Oh, I'm a congestive heart failure patient with a little gout. I better take my Lasix, my allopurinol. I better not eat a lot of sodium. I better exercise some. So I, using that app, see my care plan, just touch one or two things and immediately report back to the electronic health record how I'm doing, what I'm taking. Because although we can automate a lot of things, we don't really know if a patient adhered to a low sodium diet or if a patient took a pill. And sure, there are sensors that are emerging, like the ones from Proteus, that might sense that you take a pill, but those are pretty early. So we have to ask the patient. Well, there are certain things that are objective. Your weight, your blood pressure, your pulse ox, sleep apnea, all kinds of emerging devices that gather objective data and send them to your phone. So we gather those in this app. Next slide. For both doctors and for patients, the most important thing is to not just show data, but to actually interpret the data, provide wisdom, and a call to action. So let's imagine the congestive heart failure patient said, I didn't really take my Lasix today. Didn't feel like it. Oh, ate a large number of crunchy, salty snacks. Drank a vast amount of fluid. Oh, my weight went up 7 pounds today. And subjectively, I'm feeling a little short of breath. Well, you'll see what the app does is it says, aha, I looked at objective and subjective data, and I've concluded you are tipping this a bit into a congestive heart failure exacerbation. So we are going to make an intervention now. I need you to call this phone number. We're going to send you a visiting nurse. We're going to double your Lasix dose. We are going to work together to take away your crunchy snacks, and we are going to make you healthy. Next slide. And really key to help educate a patient on the correlation between care plan adherence and symptoms. So we don't just show them numbers, we show them graphs. Here's what you did, here's what your symptoms are, here's how it went day by day by day. You can kind of see this congestive heart failure exacerbation coming. And then we provide secure doctor-patient messaging for your whole care team. It's almost a Facebook-like secure application so that everyone can interact with you and you can ask questions. And if there needs to be an urgent intervention, it's all coordinated and communicated across the care team. Next slide. So I've talked about the Internet of Things. And lest you think that that's a peak on the Gartner hype curve, it's real. We have already deployed the application I showed you among congestive heart failure patients. But think about it. Glucometers that are Bluetooth enabled already exist. Exercise monitors exist. Pulse ox exists. Think of the devices in the consumer space that are already interfaced to your phone. The joy for us is with these middleware applications like HealthKit from Apple, and there's various Android similar functions. If all the data is sent to your phone, interfacing the phone to the EHR means one interface, one time. It's very straightforward, and since we've already done it, I can tell you it's low cost to develop, low cost to support, and has worked extremely well. And keep in mind, we are vendor neutral. As new devices emerge in the marketplace, whatever they are and whatever telemetry they gather, we will incorporate that into our application BIDMC at home. But I will tell you, there is a challenge. And I'm not going to mention any vendor. I'm a vendor neutral guy. But let's just say some device you have is a watch that measures your pulse and uses a proprietary algorithm and doesn't get your pulse right so often. Oh, another device you have is implanted and measures your pulse perfectly. So one challenge we are having is once we gather this data and we turn data into wisdom, what is the provenance of the data? What device do you believe? If you have some kind of wearable that tells us your heart rate is 20, do we call an ambulance? Or say, oh, I know the provenance of that data, it's not very accurate. We're not going to call an ambulance. And what if the patient has a bad outcome and you haven't called the ambulance? What's the medical legal liability? So I'll say that although we've done all this and we found that it's incredibly beneficial and lower cost and keeps patients healthy in their homes, there are still unanswered questions about medical legal liability, the need to inspect the data, how to filter the data and ignore the noise, and there is no what I'll call canonical list from the Food and Drug Administration of precision and accuracy of devices. So when you buy that watch in China and it's reporting data inaccurately, I know to ignore it. So for the moment, we're learning, we're going slow, we're incorporating data into the electronic health record from phones for specific use cases for which it's not so much the absolute value that we care about, it's the variance. If your scale's not so accurate, but it shows a variance of 7 pounds in a day, that's good enough. If your glucose meter isn't so accurate, but if it shows a variation of increasing 100 points in a week, that's significant. If your pulse ox isn't measured correctly, but there's a significant variance and it's much lower, that's sufficient. So pick your use case, look for variance, and as a society, we're going to figure out this provenance issue and believability issue over time. One last thing to say on this slide, we are not incorporating the raw data from Internet of Things devices into the EHR. We are taking them from the phone and incorporating them into a database. But what we put into the EHR are alerts and reminders for variance. So that way the doctors don't have to look at 10,000 normal blood pressure measurements. They're simply looking at the fact that your blood pressure was 110/50, it's now 200/100 consistently, and there's probably an intervention that needs to be made. Next slide. So far, so good. I haven't needed to hire an individual to support the Internet of Things devices. It has actually worked very well to use the phone itself as an abstraction layer because the ease of my software of getting it from the phone means that I don't have to spend a lot of money in either development or in support. So this last slide, I just have to reflect that when you look at the Gartner hype curve that starts with the era of inflated expectations, then goes through the trough of disillusionment, and then goes through a period where you refine use cases and you get eventually through the slope of enlightenment to the plateau of productivity, I believe that we are really getting to that plateau for Internet of Things devices providing patient-generated healthcare data that shows care managers and care navigators what variances occurred and what interventions could be helpful to keep patients healthy in their homes. Beth Israel Deaconess has $2 billion of risk contracts, alternative quality contracts. These pay for outcome and pay for quality. I think it's fair to say that unless you have a program that is incorporating this kind of data from patients, both subjective and objective, into care management, it's going to be very hard to survive the transition to value-based purchasing. Well, there we go. There's, I think, the 40 minutes that I promised. So let us go forward with your questions and thoughts, and certainly look forward to the dialogue.
Well, John, just before we get to that, if I can maybe, add a slight industry perspective and what we've learned actually, implementing these technologies with a number of healthcare systems in the US and in Europe over the last 3 years. Maybe I hope I would add a little bit of enlightenment to your extremely enlightening talk. I just took my blood pressure, during your talk, and it elevated itself considerably because of the brilliant talk that you just gave. So I'm going to try it and do almost as good as you. But I'll probably be a little bit more brief, just to maybe reflect, on those 4 or 5 years of having created here at what was Withings previously and now is Nokia, the healthcare department of, where our essential task is to integrate these devices that are initially for end users. How do we integrate them into healthcare, and how do we create value from this? Maybe just as a forward, I got into this business writing basically, a science fiction piece about a modern Dr. Faustus trying to live eternal life, and he would actually get there through technology. I have a philosophy background, and to my great amazement, I met engineers, telco engineers, and I met doctors who kind of shared that vision. And I think, what we're looking at today, what you just talked about, is really, this intersection of different fields that tended to ignore themselves in the past. Medicine on the one hand, teleco on the other hand, and this great dream that we all have, to live healthier lives in the long run. Well, I personally made those encounters. I met people like you, and we realized that we had maybe this perfect storm of getting these intentions together and actually allowing essentially patient-generated health data to flow into healthcare and perhaps, disrupt the way that care is today being conducted. So, I'd like to dedicate the next few slides on what I've learned, what we've learned as a company doing this. I believe that, in the same way that I was there at the right time and at the right place, this is fundamentally what patient-generated health data is. And what these technologies bring is, I think what you just highlighted is you're filling a gap between doctor consultations that nobody realized before was a huge gap. In a sense, medicine is always too late. You always go to your doctor when you're already sick. Whereas in the many examples that you've just given, there are a lot of cases where were you to have better data beforehand, well, you would actually be able to prevent some undesirable health events, that is, intervene beforehand, and you wouldn't actually even have to go to a hospital. You could do it from your right home. So this revolution, I think, in many ways, when it works, is something that we have seen work, and we have seen it because, first of all, we have been providing a technology that enables, this vision to come true. So maybe on the next slide, and I don't want to sound too commercial, but just to highlight the fact that on the next, our distinctive added value here is we started off essentially selling to consumers devices that they were already buying, except they weren't connected. We didn't try and invent a usage that wasn't already out there. We tried to improve what was already out there. People are already wearing watches. People are already waking up, and it's not necessarily in a healthcare setting. We didn't try to build new behaviors. We tried to improve existing behaviors. And what we found out connecting these devices is that first people thought we were ridiculous. So, when we first launched this connected scale, I remember reading in the papers, said, oh, great, it's the scale that tweets your weight. And everybody laughed at us. So I think John Stuart Mill said that every great innovation goes through 3 stages. The first is ridicule. The second is discussion. And the third is adoption. So I think we're now, between the discussion and the adoption. We're seeing a bit of both. But I think what made us look ridiculous is actually our greatest strength. Is we through these devices, through health tracking, through what people call quantified self, what we aimed to offer was essentially, a fun experience, gamification of tracking your own health. So people thought that self-quantifiers were freaks, basically, whereas in fact they were maybe visionaries. And what I think we've seen in this gamification is we've seen 2 things which are really the same thing, which is one is a consumerization of healthcare. Tracking your health suddenly is not restricted to people who are really sick or who are absolute athletes. It's for everybody. And because essentially the price point went down because it's a consumer device. But we've also seen that it's actually a medicalization of consumer devices. Sensors that were previously only accessible to doctors have, through the smartphone revolution, essentially become cheap enough for anybody to buy them. So I think our distinctive value proposition has been to really, sell a consumer device that is actually medical grade. We do clinical. So, what is it to offer the right data? It's first, make something fun enough for people to actually want to track their data, want to, step on their scale every day, or track their activity. But it's also about, having actually validated data that other people can use. And to my next slide, I would say, that what's interesting is when this consumer phenomenon suddenly spills over into healthcare. So on the next slide, just to illustrate this, well, we didn't reach out to the medical world, they came to us. We provided open APIs, so basically the possibility for anybody tracking his health to share this data. And it started off with fitness apps. It caught the attention of people at Apple or Google more recently, and they started building essentially the plumbing between our devices and that of other vendors and the electronic health records. So suddenly the data started to flow, and when the data starts to flow, I think there's a second disruption. The first disruption was medicalizing consumer products. The second disruption is when you start to share data. I think in the traditional sense, medical information, medical data is something that people tend to keep secret. There's the famous Hippocratic oath of, never revealing your health data to anybody else. And that's still how I think many doctors, probably not you, John, but other people are looking at medical data. Whereas in fact, when you start to digitize data, the whole point is to share it. It's information. It only gains value if you start sending this over to some people. So, I may track my blood pressure. I said it was very elevated. Well, I should actually be sending it over to you, and maybe it's just a short-term crisis or it's a real problem. But the value is only created once somebody starts making sense of it. So breaking the silos, really. Breaking the silos not just between doctors and teams, but between what's happening at home and what a clinician can have access to. In this sense, I don't think any clinician wants to be overloaded by how many steps I did today, or is the CO2 level at my house too high, or what's this or whatnot. I think there's a problem of responsibility and there's a problem of data overflow, and it's the responsibility of those remote care coordinating platforms to try and start stratifying what is actually the right data at the right time. So when can you prioritize an alert? When can you actually flag somebody as at risk? And this is an area where we're going to see a lot of progress, because basically today, I think we mentioned congestive heart failure as a use case for this. Well, I'm taking my weight data every day. If I were diagnosed as, suffering from congestive heart failure, well, my weight increase would have a different meaning. If suddenly it increases in such a way that, I might be actually doing a cardiac decompensation, gaining weight, well, here's an important piece of information. And right now, software show a part of this, but actually, it's still a clinician that will look at it. So, I think getting this right info, allowing early intervention is breaking the silos is clearly a disruption, because it's not the way most clinicians work. It's not the way that the healthcare system pays for these kind of services. It's not a value for service. It's not a fee for service model. So maybe on the next slide, what do you do when you have such information? What have we seen our partners do? Well, we've seen take a very pragmatic approach to it and look at areas where they could actually implement this and where it would make sense for them. So obviously, it's those health systems that are not just on the provider side, but actually, see the advantage of avoiding hospitalizations, of avoiding interventions at the hospital, and basically getting fees for value that they create. And we've seen them, allow the prescription not of a device. I don't think we're naive enough to think that people are going to start reimbursing just the device. What we're seeing being paid for by health plans is actually a program. And the device is the technology centerpiece of that program. It's what allows the data to flow at the right time to the right place, and basically allows the early detection of these critical conditions that you want to monitor. And there's an organization that needs to be built around this. Part of it is actually, creating care pathways, creating care flows. And on the next slide, to that organization, there are, it's not a doctor who's going to look at this data. The doctors, their core strength is clearly diagnosis, it's critical intervention. And part of what's, disruptive in the digital space is that anything repeatable can be automated by a machine. So there are things that you can start to delegate, maybe first to a clinician, a caregiver, then to a patient, and then probably completely to a machine. So, and that, I think Clayton Christensen said that, in the 19th century, you used to have to need an engineering degree to repair a car, and now, anybody can repair a car because you have these diagnosis tools. So I'm not bold enough to say that it's going to be the same for the human body, which is obviously much more complex, but I believe the trend is the same, that the more we understand the different diseases, the more we can automate and the more we can delegate. But that implies a complete reorganization of healthcare. And when I look at this intermediary, the remote care coordinators are basically a job that don't really exist today. There's health coaches, and we're going to see more of them. But if you go on to the next slide, and if we're here to do a few predictions, I look at them a bit like I look at the Uber drivers. So, they're a new job. Everybody's driving Ubers today, but fundamentally, Uber is already working on, creating driverless cars. So we'll still need the human intervention, but what technology is going to teach us is which part of the analysis, which part of making sense of this data truly needs to be, done by a human, or which part truly can be done by a machine. And I wouldn't go as far as saying that doctors are going to become engineers and everybody else is just going to show empathy and show care, but there is definitely a core specialization that is taking place as more of that care coordination is automated. And I think that's the beautiful project of creating AIs that go in that direction. So maybe on the next slide to try and finish up and conclude, because I would hope that I want to give you time to ask a few questions. To conclude, digital health is going to take place, I think, less and less within a hospital setting. It's going to happen everywhere. It will be less visible, but probably more pervasive. I'm not sure patients will be entirely referred to as patients. They might actually, it could be, we are people at risk. So a patient is defined as somebody in relationship to his doctor. And doctors, might actually more and more become data scientists or engineers or caregivers, psychologists almost. So, I will probably let the audience or John Helhamka react on this, but I was certainly very happy to share some of these thoughts with you today. Thank you.
Thank you so much, Dr. Helhamka and Alexi, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Looks like we only have a few minutes left, but we'll try to get through as many questions as we have time for. We've already had a lot of great audience questions rolling in, and the first one is, do you see the use of mobile diagnosing too time-consuming for doctors or nurses seeing patients in the office?
Well, simple answer to that question is if a clinician is paid not for office visits, but for keeping a cohort of patients healthy, they'll actually need to embrace these mobile devices. They'll need to embrace the Internet of Things and care at home. So it's all a function of how clinicians are motivated.
Absolutely. Thank you, Dr. Hlamka. So another question is asking, do you really believe that Epic, Meditech, and others are open and happy to share their information with each other?
So I think what I would refer your audience to is the Argonaut Project at argonautproject.org. Epic, Cerner, Meditech, eClinicalWorks, Athena have all agreed this year to open up their products with application program interfaces that are FHIR-based. All of the interfaces that I showed you and all the devices that we've implemented are all based on this fast healthcare interoperability resource, or FHIR approach. So the reality is, sure, by history, maybe they haven't been so open, but you will absolutely see that this is the year that APIs will open up all those products.
Great, thank you again. Looks like another audience member wants to know, how do you get a health system to get on board with a newer technology like IoT? Who should be the driver of these programs?
What an excellent question. It's never the CIO. Remember, the CIO, wrong person to approach. It has to be driven clinically. And in our case, this was driven bottom up by clinicians who looked at the emerging value-based purchasing reimbursement programs and recognized we needed new care management solutions. So work with department chairs and clinicians, the chief medical officer, and those folks who are responsible for keeping the bottom line positive.
Absolutely. Thank you again. The next question is, does anyone offer a kit that contains all the connected healthcare devices you need for well-being and interface them to a service covered by your insurance?
Well, of course, I will refer to my co-speaker. Go for it.
I think this question is a gift to us. So yes, of course. I mean, we offer scales, wireless blood pressure monitor, Wi-Fi thermometers, activity tracker, heart rate, and the truth is, this is starting to become picked up by health plans and insurance. If you look at the national health insurance systems in France, they are beginning to reimburse monitoring of congesting heart failure, and they have, defined a €600 per patient per year fee to ensure this follow-up. If you look in the USA, the diabetes prevention programs, which are essentially weight loss solutions to avoid you from getting sick, are starting or will be reimbursed in 2018 by Medicare. So, the list, I could go on and on about this, but essentially, you never cover everything, right? But we are seeing that, the big non-communicable diseases that make up most of the cost of healthcare in this country and others are, have relevant digital health solutions that can help tackle them, and reimbursement is starting. So, we're no longer too early for this. It's really happening now.
Great. Thank you for expanding on that, Alexi. Dr. Hlamka, looks like this next question is aimed at you. The audience member says, it is my opinion that the increase in physician productivity based on the changes you reviewed will radically change the physician shortage currently projected. Do you agree?
So I think the fascinating question is, how do we all practice at the top of our license? So at least my view, based on my experience in Boston, and I know Boston is like its own separate planet, is this is a team-based activity, which includes a primary care doc, a mid-level nurse practitioner, various clerks, And so the reality, and having done this for 20 years, we can triage the tasks that come from patients and families and mobile devices to those who need to see it. And the reality is, our doctors only get about a dozen messages a day, which replace phone calls, because so much of this other work can be done by other members of the team.
I think that is a great point. Thank you. The next question is about EHR companies, and it says, will the 21st Century Cures Act force EHR firms to open up access to their data for software companies to develop products that will aid in the process of care?
So for folks who have read the 21st Century Cures Act, you'll see there's a paragraph in it that says, and it's a little bit vague, admittedly, EHRs must open every data element to APIs. Now, is that toenail length and hair color? I don't know what it means. But I'll tell you, we're working closely with all of our EHR colleagues. They are absolutely embracing FHIR and the notion of API access for patients and consumers and the ecosystem of apps that my co-speaker had just talked about.
Yeah, if I can just add a point on that, in 2018, the general regulation on data privacy in Europe is coming into force, and it basically creates an obligation for any platform that collects personal data on somebody to allow this person to access his entire data and download it. So basically, you know, if you're booking a train with a railway company, or if you're on Tinder, or if you're doing Google searches, you can ask any of these service providers to give you all your history that they have stored on you, and this will include EHRs in Europe. So, and you know, a lot of these American EHR companies are also in Europe, and so, you know, they will basically by law have to allow this access. So it's basically a generalization of the blue button that's enforced here with the veterans healthcare system.
And having just returned from Europe yesterday, he's absolutely right. The general data protection regulations are going to be very potent.
Great. Well, thank you both for your helpful answers. The next question is about cybersecurity. And this audience member says, Bluetooth is the newest arena of hacking. This is an especially sensitive issue considering health data. How is this being safeguarded?
Well, I'll give you a CIO's response and turn it over to my co-speaker. For everything, there is a multi-layer defense. Imagine you have a castle with a moat, but you also have arrows and hot oil. And I wouldn't, of course, be able to tell the audience exactly what we do, but let's just say it is a multi-layered defense.
Yeah, I would add that, you know, whenever you introduce a new technology, you introduce new vulnerabilities, and you need to introduce new methods to counter that. So encryption, audit, safeguards, passwords, and so on and so forth. What this question reflects is, you know, there is a general concern on privacy and protection and integrity of data. And it's basically I think the successful companies in this space will be the one that can offer convincing technologies to secure that.
Yeah, I think that is a great point. Thank you, Alexi. Dr. Hamalka, this audience member wants to know more about the alert system at BIDH. He says, once physicians receive an alert about data variants, can they access the data that triggered this alert? If not, are they okay with that? Does not being able to access it absolve them of responsibility, or do they feel a sense of responsibility for reviewing the data?
Well, whoever asked that question is absolutely brilliant. Must clearly be a clinician, because showing an alert in the absence of data is useless. And so what we do on the very front page of our electronic health record summary, show alerts, which means things you need to act on now, reminders, things you should get to, and embedded within each alert and reminder is a link that shows you the raw data that clicked, that actually triggered the alert or reminder, and then a one-click mechanism to take action to resolve.
Great, thank you so much for clarifying. The next question is, are insurance companies investing in connected healthcare research to help bring this about?
Well, they are
So,
in a way. I mean, so there are certainly grant programs and pilot programs, but because in Boston, as I said, we have $2 billion of what are called alternative quality contracts, and that is that private payers, not just Medicare, are paying us for outcomes and quality and then giving us the choice how we achieve those outcomes and quality. So in effect, they are paying for innovation.
I would add that, it's not just research. They're paying for the implementation of these technologies. They are paying for remote monitoring of different at-risk populations, as I mentioned earlier, and they are looking at the outcomes. So, on an aggregated level of how much care they avoid. So they're not only investing, they're really betting on this, and they're actually it's a more fundamental change still. Insurance used to be a business of paying for risks after they happen, assuming that you don't control it, like a hurricane or something. But when you start to be able to manage the risk, you're no longer simply an insurer. You're actually a service provider. So it's a bit like, do I need to insure my driverless car? Probably not. I just need to pay the service provider for driving me safely. Well, I think we can say the same about digital health. I might not actually need to pay the same thing for ensuring, a health problem if I can pay a service that prevents me from getting it. So, I mean, at least that's, the path we're walking.
Great. Well, thank you so much, Alexi. That is actually all the time that we have for today. So I want to thank Dr. Halamka and Alexi for their excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thanks so much.
Thank you so much.